Hello everyone, welcome to The Social Doctor, and this is Dr. Ayushi. The Social Doctor is a platform for the doctors by the doctors, where we are on a mission to help each and every doctor with his or her career growth. And we do that by discussing journeys, experiences, and knowledge from successful medical practitioners. And today we have Dr. Indu Bansal with us. She is a director in the Department of Radiation Oncology in Narayana Hospital, Gurgaon. And so she's here to discuss about the branch of radiation oncology. What is it all about? How has she progressed in it? What are the recent advances coming up? And what is the kind of career growth in that? Welcome, Doctor, to the platform. It's really nice to have you here.
Thank you so much, Dr. Ayushi, for having me here. And a very warm good morning to everyone who has spared their time on a Sunday, beautiful Sunday morning, on a beautiful Sunday, sunny morning, actually. So, you are doing an excellent job. It's really nice to come and talk to you on this platform.
Thank you.
Thank you for having me here.
Yes. In fact, we are glad to have you here. It's something that we really love, and it's always so nice to talk to you. I must actually mention that. So now let's start with the topic. What firstly, how has your journey been till now? It has. I'm sure it has been amazing. What has your journey been, and how did you progress?
I graduated from Rohtak Medical College and I joined MD program in 1996 in radiation oncology. And of course, I passed out in 1998. So it's close to 22 years now post MD radiotherapy. And I must say that it has been a very gratifying experience. The journey is definitely not so easy because I passed out from Rohtak Medical College, which is a very I had a very lovely department, very loving guides, teachers, Dr. Das, Dr. Huda. I mean, excellent people. You cannot have better teachers to guide you. So I was blessed to take training under them. And I have the opportunity to work with some excellent and topmost people in the branch. Dr. Tejinder Kataria, doctor at Rajiv Gandhi Cancer Hospital. Then I worked with Dr. Sapna Nangia at Batra Hospital, Dr. Ghosh. And then I worked for 7 years and had the opportunity to learn a lot, I must say, from Dr. A.K. Anand. And then I worked in Artemis for 3 years. And now for 1.5 years, I'm in Narayana Super Speciality Hospital. So I set up the department there of radiation oncology. So it was another learning experience for me. So I can say that I worked in all types of hospitals. Like I graduated from a government medical college, then I worked in corporate hospitals, from middle level corporate hospitals to high class corporate hospitals. So it's a totally different experience in working in different hospitals. And then I did a fellowship for some time in AIMS also, and I had been to world class institute, that is MD Anderson Cancer Institute as well. So I can say that I have had the opportunity to work at the best centers and government setups as well. So I can say that there was a lot of learning from each and every center where I worked, and I gained a lot from each and every place.
Yes. I'm sure that actually helps as a doctor to to work in at varied places. So now let's discuss what exactly is radiation oncology, or radiotherapy. What all gets covered in that?
Okay, so that's a very basic question, and I think it's important that you asked me because many people, in fact, I must say that even doctors, very senior doctors, they confuse radiation oncology with radiology. So there is a lot of difference between the two branches. As the radiology means study of X-rays or studies of, so radiology is basically a diagnostic branch plus a therapeutic branch as well, because there are a certain procedures also which are being done in radiology department. So that is basically diagnosing the disease. Like you take X-rays, you do CT scans, MRIs, then you do a lot of procedures like ultrasound guided biopsies, you do pleural tapping, and so many cardiac procedures. And interventional radiology is another branch. So radiation oncology, as the name suggests, is a branch of oncology which studies and talks about treatment of uh, treatment of not just cancers, but I must say that radiation is now being used for treating a number of benign, that is non-cancerous diseases as well. So radiation oncology basically involves treatment by either high energy X-rays, which are being used in linear accelerators, or it can be gamma rays, which are used in cobalt machines. And there are high energy energies also, like protons, carbon ions, and there are brachytherapy procedures, which is a type of internal radiation. So basically, when you offer radiation, it can be an external radiotherapy or it can be an internal radiation. So external radiation means when the source of radiation is away from the area which is to be treated. So which is delivered by, say, linear accelerators, which deliver X-rays from a distance, and through that the area which needs to be treated is targeted. As against brachy means near. So therapy means treatment. So what it means is that you are placing radioactive sources inside the tumor, and the radiation dose is being distributed to the structures around the tumor. So it is basically being used in a number of sites, most commonly being for the treatment of cervical cancers, endometrial cancers, then for a number of head and neck cancers. Intraluminal brachytherapy is used for treatment of bronchial cancers as well as esophageal cancers. Then intraluminal brachytherapy can also be used for, say, gallbladder if there is any biliary obstruction. And then for soft tissue sarcomas, it can be used as a mold treatment, as a surface treatment for skin tumors. So it has varied advantages, and the scope, I must say, is very much varied, because you can treat a tumor as small as 5 mm to whole body, which is being used in total skin electron treatments, or it can be used for total lymphoid radiation, as in cases of hematological malignancies. So, and with now we have the techniques to not just target the tumor, because there is a lot of advancements in diagnostics. So because of advancements in diagnostics, the tumors are being detected earlier, and now we are able to focus the radiation to a very small pinpointed, and you cannot just pinpoint radiation, but you can also look at the tumor and treat it. That is the beauty of radiation. So you can track the motion of the tumor at the time of treatment, and then you can vary your radiation, as well as you can adapt your radiation beams to the shape of the tumor. So if a tumor is shrinking during treatment, you can modify your radiation beams.
Correct.
So radiation is something which is used for almost all body sites from head to toe. So radiation is something which I must say that at any point of time, around 60% patients, cancer patients, they need radiation. And now, because people are living longer, and with advanced techniques like stereotactic body radiotherapy, stereotactic radiosurgery, we are able to give radiation to the tumors again. And it can be for very early tumors. It can be used as a single modality to, and you, if the patient is not operable, say for early stage lung cancer, you can offer radiation, which is an OPD procedure. So it's a very beautiful modality of treatment. And as I said, it is used for a number of benign tumors as well, like pituitary adenomas, for craniopharyngiomas, for vestibular schwannomas, which are called as glomus tumors. Then it can be used for cavernomas, and so many other benign tumors as well. So it's a very beautiful modality of cancer treatment.
Correct. That's absolutely right. Especially with the advancement and everything, it has helped. So now you have mentioned about all of this and this and the uses of it. So there are a lot of myths attached to the radiotherapy. What are the kind of myths that that you think are relevant?
Okay. So, of course, there are a number of myths. Number one is that people feel that radiation cannot cure a tumor. which is an absolutely wrong thing. Radiation is used as a sole modality for a number of tumors, say for head and neck malignancies, for cervical cancers. It can be used as a single modality for early cases. And as I said, if there's a stage 1 lung cancer, then you can just offer radiation. For very early prostate cancers, say stage 1, you can give stereotactic body radiotherapy, where you can deliver just 5 sittings of radiation. It's as so that it's a 10-15 minutes treatment. Patient comes to the hospital walking, goes back to the hospital in 15-20 minutes. They don't need any admission. So one is that radiation is definitely a curative treatment. Number two, लोगों को ये लगता है कि ये जला देता है सब कुछ, which is, people say it burns everything, and which is not right. So with cobalt machines, there was some dark discoloration of the skin, and there is some dark discoloration of the skin with linear accelerators also. But these are all reversible side effects, and we have very good ointments to relieve those side effects. And number three myth is that every radiation therapy leads to loss of hair. It leads to a lot of nausea, vomiting, and people feel that it will not be tolerated by majority of the patients. So, which is an absolutely wrong myth, because as I said कि ट्यूमर्स को ये ठीक करता है, तो इसकी वजह से हेयर लॉस जो होता है, दैट इज ओनली if you are giving radiation to the head, to the scalp. But suppose a patient is getting radiation to breast area, she will not have hair loss. If a patient is getting radiation to the arm, she will have hair loss only in the area which is being treated. So because of advanced techniques like 3D CRT, IMRT, IGRT, we have the now techniques to minimize the side effects and give target radiation only to the tumor and spare the surrounding structures. So like if I tell you that now, even if I'm giving radiation to the brain for a patient, we can spare the scalp, so preventing hair loss. We do hippocampal sparing, that is, you prevent the cognitive functions of a patient. You spare the parotid glands, so that patient does not develop dry saliva after the end of radiation. You can save teeth, mandible, temporomandibular joints, a pituitary, then penile area, testicular doses. So there are so many techniques through which you can do sparing of the normal structures, and we can, as I said, minimize the toxicity to the surrounding structures. So radiation is not always toxic. In fact, it's a very, very good modality for instant pain relief, like patients who have a bone collapse because of bony metastasis. You can offer them radiation, and it leads to a lot of pain relief. And one thing, the beauty of radiation is that where your scalp cannot reach, the inaccessible sites which are inaccessible for surgery, even those sites are easily reachable by radiation. So it's not that if a tumor is not treatable by surgery or chemotherapy, then radiation cannot treat that. Correct. So it leads to side effects in the limited area which is being treated. It does not have distant side effects as you expect from chemotherapy or from other agents. So it can be used as a single modality. It can be used in combination with surgery. It can be used after surgery. It can be used in combination with chemotherapy. And the advantage of radiation is that it can be used for any stage of patient. So even for stage 4 patients who have a very advanced disease, radiation can be used to treat their pains, to improve their quality of life, to prolong their life. So now radiation can be offered even to liver tumors, say a patient with hepatocellular carcinoma, even for adrenal tumors. It can be used as for re-radiation modality. So there is a varied scope of radiation, I must say now.
Yes. So we have got one question by Dr. Safa. He's asking that, is there any interventional procedures in radiation oncology?
Oh, yes. Yes. So I don't know what does he mean by interventional procedures, but basically I mentioned about two techniques of radiation. One is external radiation and another is internal radiation, which is known as brachytherapy.
Mm,
So suppose there is a patient who has a tumor on the side of tongue, on the lateral border of tongue.
mm,
Then what you do is under anesthesia, you place certain needles under anesthesia in the tumor, inside the tumor, and then you replace those needles, stainless steel needles, with plastic catheters, and you leave them in place, and then you deliver radiation only to that area through an iridium 192 source. So that similarly you can use it for soft tissue sarcomas. So these procedures are all done in under anesthesia in operation theater. So for a patient with advanced carcinoma cervix, for those who have parametrial involvement where you want to give lateral dose to the parametria, you can use an interstitial applicator wherein you put in needles inside the tumor, and you give radiation only to the tumor, but at the same time you can spare the bladder as well as the rectum. So this can be, in fact, these all techniques are being used. And as I said, for say a patient has a anal tumor, so you can use brachytherapy there. So for there are so many sites where brachytherapy can be used as a part of interventional radiation oncology procedure.
correct, correct, correct. Nice to know all of this, ma'am. So now with the recent advances, what are the recent advances that have been coming up in radiotherapy as well?
Okay. So I will cover this part under two sections. One is external radiation and another is internal radiation.
Okay.
So external radiation, as I said, is known as teletherapy.
Hmm.
So when I started my career, that was in 1996, I worked in a cobalt machine, wherein you would place the radiation. Suppose someone has a tumor on the base of the tongue, so we will direct one radiation beam from here and one radiation beam from there. And so what is happening, that anything that is coming in the path of radiation, be it lips, be it buccal mucosa, be it cheek, tongue, teeth, parotid gland, some mandibular gland, some mental area, everything would get the same dose. But now we have advanced techniques like three-dimensional conformal radiation, wherein what you do is you shape the radiation beam as per the shape of the tumor in 3 dimensions, and then you in a way what you are doing is that you are reducing that amount of normal tissue which is getting radiation. Because of that, you are able to push a higher dose to the tumor. Okay, but in this what is happening is that the area which is surrounding the tumor, whatever is getting in the radiation beam, is also getting the same dose. So there is another technique which is known as IMRT, which is intensity modulated radiation therapy. So as the name suggests, you are modulating the intensity of the radiation beam in such a way that you will give a very high dose to the tumor, but at the same time spare the normal structures. Say a case of nasopharyngeal carcinoma, where the tumor is sitting behind the nose and it is sitting in between the eyes. So what you are doing is you will give a very high dose of radiation, say 70 units to the tumor, but at the same time you will instruct your computer not to give, say, more than 5 to 6 gray to the lenses, or you will restrict the doses to the optic nerve, to the chiasma. You will restrict the doses to the brain stem. So what you are doing is that at the same sitting, you are giving higher dose to the tumor, but at the same time you are restricting the dose to the normal structures. Then there is another technique which is IGRT, which is image guided radiation therapy. What it means is that at the time of treatment, you see the tumor, and if suppose you're treating a case with CA prostate, and there would be some bladder filling and there would be some difference of filling in the rectum. So what you do is that at the time of treatment, inside your treatment machine, you have a camera fitted. You take the image and see whether your radiation beam is missing the tumor or it is covering the tumor. So if it is missing the tumor, you bring your tumor inside the beam of radiation and then you treat it. Similarly, because lung cancer, lung moves. So you focus your radiation beam as per the movement of the tumor. So then we have very highly sophisticated techniques like stereotactic body radiotherapy, which is being used for primary lung cancers, metastatic lung cancers, bone tumors, which is being used for hepatocellular carcinomas, liver metastasis, adrenal tumor, para-aortic lymph nodes, re-radiation of lymph nodes, re-radiation of recurrent head and neck cancers. So what you are doing is you are giving very tight margin to the tumor, and rather than giving your radiation dose over a number of treatments, which is a typical radiation treatment lasts for say 30 to 35 days. So rather than that, you give the treatment in 5 sittings. 15 days treatment, 5 sittings, and so even if your tumor is sitting within 3 millimeter of the optic nerves, you can spare the optic nerves and treat the tumor. And so that is why if you are giving radiation using these techniques for brain, it is known as stereotactic radiosurgery for brain. If it is being used for body, it is known as stereotactic body radiotherapy. And so because of this, if a patient has brain metastasis, you don't need to give whole brain radiation. You can just give a highly targeted radiation only to that site of metastasis in the brain. So you preserve the cognitive function, you preserve hair loss, and you can give retreatment also. So, and as I said, it can be used for a patient with skin tumors, say mycosis fungoides. So you give total skin electron treatment. So these are all advances in treatment. And in brachytherapy now, there are MRI based applicators available. So you can do an imaging in MRI, and then you see the tumors better, and then you target the radiation doses. In fact, I'll tell you something which is absolutely new. You all would be stunned. I have a very dear colleague of mine who is the head of CyberKnife Center in Italy. And he has just devised a treatment where they are using radiation for treatment of spasticity. Can you believe it? A person who is spastic, you give radiation and the person is walking now. It is being used for for treating cardiac arrhythmias, for Parkinsonism, for intractable epilepsies. These all things are under pipeline. So I think this is an absolutely stunning branch where you can achieve a lot and improve quality, not just extend life of a patient, but improve the quality of life as well.
Correct. And especially now when you mentioned about the recent advances coming up, I'm sure this will revolutionize the whole system, because treating all of this is a big deal, and that way this branch is really advancing a lot. So now when understood what exactly is radiotherapy and what are the advances that are coming up, so let's understand if a student pursues this branch, what are the kind of job opportunities are available for the person, and looking forward to.
Okay, so that's a very important question, and I think today's youngsters are very much focused on their career, and they really want to know what are the branches. So I must tell you that one thing that you have to understand, the difference between radiation oncology and medical oncology is that radiation oncology, because radiation is being offered on big machines, so they are definitely very, very, very costly setups. Like I'm working on TrueBeam, which is the machine itself costs you around 25 crores. And it's a proton treatment. Proton is as close to 100 crores. So these are very, very costly machines. So if you are working, if you decide to go for a radiation, to become a radiation oncologist, you have to understand that then you have to always work in a setup, okay, either in a government setup or in a corporate setup. It's not like a gynecologist who can set up a clinic anywhere and sit down and start working from day one as soon as you passed out your MD. So in the problem is that in most of the government setups, except for few like AIMS, most of the centers, they may not have the advanced technology, although now a number of centers are coming which have the advanced technologies. So in most of the government setups, they have cobalt machines, but now a number of centers have state-of-the-art linear accelerators as well. So if you have worked in a government setup, in a small government setup where you don't get the opportunity to learn brachytherapy, or you don't get the opportunity to work on these advanced techniques which I just mentioned about, then it would be a good idea that you please go to some good center, train yourself well, And as I said, unfortunately, most of the radiation facilities now, they are centered in metro cities or in some medium level cities, but villages or remote areas, they don't have access to radiation facility. So if you plan to join this branch, then you may not be able to stay close to your place, to your parents' place. You might have to move out, and you might have to go out. And now, as I said, because radiation, the centers are limited and the seats are also limited. So a job might be a little problem because you cannot work on your own. So every student who passes out has to work in a setup. Okay. And in private setups, there is nothing like retirement. So people keep on working till long. Okay. So the jobs are not that often, or they are not that frequent. But I must also, I don't want to disappoint anyone. At the same time, there are certain facts which I want to put you across. At this point of time in India, we have close to 565 teletherapy machines. And although the requirement is close to that of 1250, so we are still short of around 700 teletherapy machines. Okay. Gradually, I think 40 machines are being commissioned every year, but 15 machines, they go out of service. So in a way, 25 centers are added every year. So the demand is definitely going to increase. And one thing that I also want to say is that oncology is something, cancers is going to be the number one disease, non-communicable disease, which will affect people. So if you talk about the current data, there are around 10.5 lakh cancer patients, and the number is going to definitely going to increase by, I think the number is going to go up by 15.7 lakhs by 2025. So earlier cardiovascular diseases used to top the list, but now as the longevity of people is increasing, so people are going to live longer, so more and more number of people are going to have cancers. So oncology is definitely going to be in demand. It's definitely going to be in demand. So the number of radiation centers will definitely go up, and there might be some difficulty in getting a job at this point of time. But if you are willing to move to smaller places, you can definitely get a good branch. So it's not that tough, but you have to be willing to move out of your comfort zones, definitely. And second thing, I just want to break one more myth here is that people feel कि आराम करना है तो radiation oncology ले लो. ठीक है, I mean कि night duties नहीं होती हैं. So I must say that scenarios are changing. In government setups, sometimes you don't have, this department closes at 4 o'clock or 5 o'clock, but in private setups, like when I was in Max Arcade, we used to work till 7:30, 8 o'clock in the evening. So if you are working on high class techniques, like SRS, SBRT, brachytherapy, then you have to put in a lot of effort, and it's not a easy catwalk. You have to really slog in, you have to read the log. There is a lot of literature coming every day, a lot of advancements happening in radiation oncology, so you have to really keep up to the date. Correct. So आराम परस्ती की branch नहीं है ये. It needs a lot of hard work.
Yes. No, actually, nice to know, because this is a myth that at times people just pick up some branches for a relaxed lifestyle. But yes, this myth is being broken is good. So now, if a person, now, as you already mentioned, that with tier 2, tier 3 towns, scopes are really limited. It's mostly for the metros and for the upcoming, big cities. So now, if a person plans to get into the branch and joins a place in a metro, a fresher, what is the kind of pay scale a person can expect from the branch?
Okay. I can say that a DNB student, okay, who joins DNB or who joins MD in radiation oncology, It also, of course, the salaries vary from place to place. So if you're working in a government setup, the salaries are different. You are working in a private setup, the salaries are different. And it also varies from the city that you are working in. Okay, so like in a government setup, I think maybe I might be wrong, but a resident typically earns somewhere around 60 to 70,000 per month. DNP resident, usually they get around 80,000 in a way. So post DNB residents or post MD residents, they get somewhere around 90,000 to 1 lakh. Okay, so for a post MD 5 years, it would vary somewhere between 1 to 1.25, or it could be 1.5. So then of course it depends as your number of years of experience gain up, and if it depends on the center that you're working in, then the salaries of course go up. So you may earn, if you are suppose 7 years experience, and it depends on what model you are working on. So if you are working on a fixed salary, or if you are working on some share plus fixed salary, then the remuneration may vary. So it may be around 3 lakhs. But if you are working on a sharing model and it's a busy center, you have a good patient load, you may earn somewhere around 4, 5. There is sky's the limit then.
Correct. No, actually, we just approximately range for the freshers to have an idea. So now, when we have discussed so much about the branch, anything that you want to, tell the upcoming students to pick up the branch to motivate them, something that you find is amazing, and especially, also focusing on your lifestyle. What is the kind of lifestyle that has been till now with the branch, and and also something to motivate the kids.
Okay. So, number one tip that I want to give the students is that, according to me, no branch is a useless branch, or no branch is the topmost branch. Let me tell you, when I joined MD, radiation oncology was not a very much sought after branch. Let me be honest with you. But my father, I must give credit to my father. He had the vision, and he said, Indu, you must go and choose radiation oncology, because number of cancer patients are going to increase. And at that time, I was not really happy, let me tell you. But but what I found was that for oncology specifically, you need to have a lot of empathy. Okay, you cannot treat a cancer patient by just, ये मतलब आप उस intention से नहीं जा सकते हो कि मैं तो कमाने जा रहा हूँ. So because these patients are in a lot of agony, they are at a lot of physical pain, financial pain, mental pain, family support नहीं रहता है, facilities नहीं होती हैं. So पहली बात तो ये है कि आप कोई भी ब्रांच चूज करिए, चाहे आप स्किन ले रहे हो, चाहे आप रेडिएशन ले रहे हो, चाहे आप गायनी ऑन्कोलॉजी ले रहे हो, अगर आपके अंदर पैशन नहीं है, आप किसी भी फील्ड में सक्सेसफुल नहीं हो सकते, इवन इफ यू हैव वर्कड एट द बेस्ट ऑफ सेंटर्स. I have seen people who have graduated from AIMS, but they are nowhere. I have seen people who worked at a very normal center, but they have marked a niche for themselves. Okay, so until and unless you have a passion to excel, until and unless you have a passion to learn, until and unless you want to pursue your dreams, you cannot excel in any field. Okay. Second thing, ये कभी मत, एक चीज मैं डेफिनेटली बोलूंगी कि initial years of your career, please try to work at some good center, even if you have graduated from any average center, but at least go for some trainings, for some fellowships to the centers, to the best centers in India as well as abroad. As I said, I worked for some time at MD Anderson Cancer Center, which is the best cancer facility in the world, and second is Memorial Sloan Kettering. So try to visit any of these centers, because it changes your outlook completely. Number three that I want to tell you, this tip is specifically for females as well, because for females, this is actually for males as well, because of the marriage, because of social issues, because of your family issues, sometimes there is a break in your careers, or you have to make decisions which you are not happy about. But let me tell you, even if you have a gap due to any reason, you can always bounce back if you really want to.
Correct.
Okay. So, number 4 tip that I want to tell you is never stop asking questions. Let me tell you, no question is stupid. If you don't ask questions, you will never learn. People might think you that इसको इतना भी नहीं आता, but अगर आप पूछ लोगे तो हमेशा के लिए कुछ सीख लोगे, नहीं तो आप हमेशा ही कभी कुछ नहीं आता वाली रेंज में रह जाओगे. अम, एक और चीज है जो मैं बहुत ज्यादा बिलीव करती हूँ जिस चीज में कि whenever you are treating or whenever you are doing your, जब आप डिग्री भी ले रहे हो उस टाइम पे हमेशा हर चीज को ये कोरिलेट करके देखो कि हाउ इज दिस गोइंग टू बी, हाउ एम आई गोइंग टू यूज दिस इन क्लिनिकल प्रैक्टिस, इसका इम्प्लीकेशन क्या है. ठीक है. और जो चीज आप एमडी के दौरान नहीं सीख पाते हो उन एरियाज को वापस सीखना थोड़ा मुश्किल होता है. सो डोंट वेस्ट योर ये, मतलब क्योंकि क्या होता है जब आपका पीजी में सिलेक्शन हो जाता है, यूफोरिया में आ जाते हैं, हाँ अब तो मैं डॉक्टर बन गया. So you are little, complacent. So in medical field, every day is a learning day. You learn from your ward boys, you learn from your nurses, you learn from your colleagues, you learn from your peers, you learn from your seniors, you learn from your patients. So never ever stop learning. So और शुरू के सालों में जो आप मेहनत करके एमडी कर लेते हो, उसके बाद में अगर आपका ब्रेक आ जाता है, फिर बेबीज, बच्चे, फैमिली कमिटमेंट्स की वजह से कई बार बाद में आप दोबारा एमडी के लिए नहीं जा पाते हो. सो कोशिश करिए कि अभी आप थोड़ी सी और एक्स्ट्रा मेहनत कर लें. और आजकल बहुत ऑनलाइन कोर्सेस हैं, आप लोगों के पास एटलीस्ट एक बहुत बड़ा एडवांटेज है दैट यू हैव यूट्यूब वीडियोस. वी नेवर यूज्ड टू हैव दैट. हमें तो लिटरेचर लेने के लिए, एक आर्टिकल सर्च करने के लिए रोहतक से हमें दिल्ली आना पड़ता था. वी डिड नॉट, उस टाइम पे इंटरनेट जस्ट शुरू हुआ था. सो नाउ you are connected to the best of people in the world. You can always connect to the topmost people in the branch. And let me tell you, nobody would refuse you to guide you. So seek help, talk to your seniors. There is no harm in visiting a good facility and see कि what is, कि अगर मैं कल को radiation लेता हूँ तो what type of machines I'm going to work on. If I'm going to become a skin specialist, visit a good dermatologist, visit a good dentist facility. So 2-4 जगह पर आप जाके देखिए, लोगों से बात करिए, जो लोग अभी उस फील्ड में हैं, at the best of centers, at average centers, उनसे बात करिए. And there is, I always believe कि sky is the limit. You can achieve whatever you want to.
Correct. That's so true. And it's as mentioned by you, it's more to understand what you want to do by viewing and visiting people and understand.
Actually, one thing, एक चीज मेरे ब्रदर ने मुझे टिप दी थी जो मैं आज सबको दे रही हूँ. What he said was that I think initially you have to sit and decide what do you want in your life. Do you want to be a topmost professional? मतलब what is important for you? Is name important? Is fame important? Is money important? Is family important? Okay, like अगर किसी को है कि मुझे तो सेवा करनी है, I'm not bothered about money. Someone might say कि मुझे इतना कमाना है कि बस मेरे पास तो I have the best of facilities. किसी को ये है कि मुझे इतना कुछ करना है कि इस ब्रांच को मुझे अपलिफ्ट करना है. ठीक है. So you have to decide what is your priority. You have to, कुछ छोटी छोटी चीजें आप एटलीस्ट डिसाइड करिए. Do you want to work in a government setup? Do you want to work in a private setup? So यहाँ पे मैं एक टिप दूंगी कि keep both the options open. अगर आप मेडिकल कॉलेज से आप डिग्री लेते हो और अगर आप 3 साल वहां पे सीनियर रेजिडेंसी कर लेते हो तो आपके पास गवर्नमेंट जॉब का ऑप्शन भी खुला रहता है. If you move out after your MD from the government setup and join a private setup, then you will never have the opportunity to go to a government setup. So if you have some willingness कि मुझे गवर्नमेंट सेटअप में काम करना है, मुझे प्रोफेसर बनना है, मुझे गर्मियों की 1 महीने की छुट्टी चाहिए, मुझे सर्दियों की 15 दिन की छुट्टी चाहिए, वो प्राइवेट में नहीं मिलती आपको. So think of little such things as well.
That's true. And this is so important to prioritize that leads to a satisfied life. That's correct. So Dr. Safa has one more question. He's asking, can you please suggest the colleges to pursue radiation oncology, good colleges, if you can?
Government setups or private setups? So if you talk about government setups or the best of centers, governments, so I must say, if you can go to Tata Memorial Center, there's nothing like that.
Yes.
मुझे एक regret है, I could not go to Tata. Let me confess it on public platform. So Tata Memorial Center में जो learning हो सकती है वो आपकी कहीं पे भी नहीं हो सकती. That's the best center. If you want to talk about AIMS is definitely a good center. Kitwai is a very good center. Amrita Kochi is a very good center. So there are a lot of good centers. Okay. Private setups में अगर हम बात करें तो दिल्ली में like Max Saket is a very good center to learn. Apollo है, राजीव गांधी कैंसर सेंटर है. So यहाँ पे DNB के आपके पास options हैं. So you get the opportunity to work on the best of machines. And on all the technologies, you get the opportunity to learn both external as well as internal, teletherapy as well as brachytherapy. Now, brachytherapy is not being done at many centers. So if you want to learn the trick of the art of both the techniques, then choose a center where both are being done in huge numbers. Like Tata Memorial is a center which is doing a lot of brachytherapy. AIMS does a lot of brachytherapy. दिल्ली में बहुत सारे centers में brachytherapy minimal होता है, मतलब सिर्फ cervix का हो गया, but interstitial brachytherapy वो थोड़ा कम होता है. So अगर आप by chance किसी ऐसे center पे काम करते हो जहाँ पे ये facilities नहीं है, तो भी आप बाद में fellowships के लिए या 1 महीने के या कुछ months के trainings के लिए आप जा सकते हो.
Correct. Yeah. Actually, this is very insightful to understand which are the better places to go for, because with so much of advances, this actually helped. Thank you so much, ma'am, for such an insightful session. I'm sure it is helpful for all the viewers. This will help them to guide them in the right direction, and we are really grateful to have you here for the same.
Thank you so much. Thanks for joining here, and thanks to you for having me here, and my lots of best wishes to all the aspirants, and I know all of you are going to do great in your life. My best wishes to you.
Thank you so much, ma'am. Thank you everyone for joining us today at this time. Do share this with your friends and colleagues, because this will help them also to understand about the branch and to get a deep insight about it. Also, do follow us on our YouTube and Instagram pages. You can find all our old videos there, which can also help you to understand about different branches and help you in your career growth. Thank you so much, everyone. Thank you so much, ma'am, for being here with us. Thank you. Bye-bye, everyone. Bye-bye.